Okay, well, welcome everybody to our webinar tonight about sore feet. Do you have sore feet, strains, sprains, and pains? What you need to know. We're excited to have you all here tonight. Some of you may be joining us from a very hot part of the country. So we welcome you, and hopefully you're in a cool and air-conditioned spot. So let's begin. And of course, we want to start with our land acknowledgement. And the Lifemark Health Group team acknowledges that our work spans many territories and treaty areas. And we're grateful for the traditional knowledge keepers and elders who are with us today, those who have gone before us, and the youth that inspire us. We recognize the land and the benefits it provides all of us, and we invite everyone to reflect on the past and present history in their particular geographic region for us each to think about what we can do to work towards reconciliation. So we're going to start with a little bit of housekeeping and just letting you all know that we're not going to be using the chat, but the Q&A is live, and Jonathan is very busy here answering your questions as we go along. Also, within Zoom, you can change your view if you want to zoom in and just have the speaker on your screen, or if you want to see more of a view of all of us, just in the top right corner of your screen, there's an icon that you can change that view if you want to play around with that to whatever is your liking. We do want to remind you that we're unable to give individual advice here, and this is shared for educational purposes and is not specific medical advice. Today, we're happy to say that you are able to see us, and we can be brought to you from Lifemark in partnership with PC Health. So Lifemark, if you're not familiar with us, we're Canada's largest physiotherapy company. We are spanning across the country with over 300 locations, and certainly physiotherapy is only part of what we do, and we provide many other clinical services across the country. And as I said, we're in partnership here today with PC Health, and Olivia will have you speak to the PC Health for us.
Yeah, so hello, everybody. As Andrea said, I'm Olivia, a part of the PC Health team. And for those who don't know about PC Health, it is a free service that is available on app and web that allows Canadians to conveniently access healthcare and achieve better health outcomes. The app is available for download on the App Store and Google Play, and you can find our webpage by searching up PC Health online. There are many services that PC Health offers to its users. Users can book virtual or in-person care appointments with pharmacists and other healthcare professionals, all in one place. You can also see the available services at your local Shoppers Drug Mart pharmacy. On the PC Health app, you can even live chat with a pro in real time. PC Health also allows you to manage your prescriptions. You can refill your prescriptions without having to call your pharmacy, and you will receive a pickup notification when it is ready. Through PC Health, you are also able to view all of your medication history, making it really easy and accessible to manage your prescriptions in one place. PC Health app users can also kickstart their health care journeys with over 150 educational health programs. Health programs were designed to help you develop healthy habits and provide you with tips on how to live a healthier lifestyle. They offer educational content and daily goals across multiple lifestyle categories, from diet and nutrition, fitness and exercise, mental health, and there's so much more categories on the app. While completing health programs, you can earn PC Optimum points. This is great if you're looking to achieve specific health goals or just want to learn more about topics that interest you. You are able to connect to the PC Health app to your wearable device, such as a Fitbit or Apple Watch. This can help you track the steps you take and other health metrics. You can also use it to track your visits to PC Health stations, to track your blood pressure, heart rate, weight, and a lot more. PC Health stations are the blood pressure machines in the Shoppers Drug Mart pharmacies. The goal of PC Health is to really help you achieve your health goals and allow you to conveniently access healthcare. If you download the PC Health app and sign in for the first time, you will earn 500 PC Optimum points. We also have a bunch of step challenges taking place right now where you can earn PC Optimum points by just walking. So if you scan the QR code and download the app, you can enroll in these step challenges and you can also earn 500 PC Optimum points. Thank you all for listening and for the Lifemark group for having me today.
Fantastic. Well, thanks so much for joining us, Olivia. There's so many awesome things that you can get and find on the PC Health app. So please get in there and learn a whole bunch more by joining the PC Health app. Or if you have it already, start digging in. It's tremendously valuable. So thank you so much. Now, we've gone a long way to bring you two people who really know feet. Cregg and Paul are joining us tonight, and Cregg joins us from Edmonton. He is a physiotherapist and the clinic director of the Lifemark Edmonton Sport Institute. Cregg has multiple letters behind his name, probably too many to go through. He has his original degree back in the late 90s, where many of us got educated in, was in anatomy cell biology. Like, that just sounds super smart. And then he went on to get his BSc in physiotherapy. He is a manual and manipulative orthopedic therapist. He is a gun IMS needler, among many other things in his postgraduate education. He certainly has some tremendous experience. He sees the regular weekend warriors. He also has experience with Olympic athletes and professional athletes as well. Cregg is really hoping that the Oilers continue on this winning streak, as I hope most of us on the call are. And from the other end of the country, out in the Maritimes, Paul Makinen is coming to us. Paul is a certified Pedorthist who has worked in the field for over 20 years. So he assesses people for custom foot orthotics and addresses footwear and footwear recommendations, as well as bracing solutions. He comes from us from Acadia University with a Bachelor of Phys Ed, also got a diploma in massage therapy, and then did his training as a certified Pedorthist. And he's been treating patients in Nova Scotia ever since. Paul is a member of the Pedorthic Association of Canada and the College of Pedorthics of Canada. His expertise in foot and lower extremity conditions has allowed him to speak at local events and educate people on orthotics and proper footwear selection. So the difference between Paul, what he does, and what a podiatrist does is that podiatrists are medical doctors who specialize in foot care, like nails and skin and stuff. And in some places, they can actually do minor surgeries. So we're all here to learn about feet. And Cregg, we're going to get you to kick us off and talk a little bit about anatomy, some of maybe the high level stuff, as well as the role the foot plays.
All right, thanks for the introduction, Andrea. Yeah, I'll take a high-level approach here. And so first off, thanks to everyone for coming out to this webinar tonight, this afternoon, tonight, wherever you are across this country. We really do appreciate your attendance. So the foot and the ankle really, to me, is an engineering marvel. It's a complex series. For any of you who have a mechanical or an engineering background, it's really a complex series of pulleys, of levers, of springs, of hinges, and of mortises. And most importantly, it really requires a combination of, or a balance, if you will, of flexibility. So it has to be able to mold and adapt to the ground. It has to be able to help with provide balance. It also has to be able to work as a shock absorber. After all, it's the first point of contact that we make with the ground. And so, but in addition to that malleability or that molding that it has to be able to do with the ground and any surfaces underneath it, it also has to be able to act as a rigid lever. And that rigid lever is super important, in particular in the case that, when we're weight bearing on that foot, as we come through, and we'll talk about this in a minute, but as we come through, there are certain forces that are going to be put through that foot. So that we need the foot to act as that rigid lever for those forces to be transmitted through there. We also need the rigid lever to help with propulsion from one step onto the next, into the next. So the area, again, it's a very complex area. It consists of 28 bones. It consists of 23 muscles, 33 joints, and well over 100 ligaments. And those ligaments are those little elastic bands that keep the joints nice and tight. So just to put things into perspective, on average, we walk roughly 7,500 steps in a day. Now, I certainly take considerably more than that, but on average, about 7,500 steps a day. And that equates to about 160,000 kilometers in a lifetime that we walk. So you can imagine that if there's any breakdown, any load-bearing problems or any traumas, insult to the foot, it can have a significant impact, not only on the foot and on the ankle, but even further up the chain, up our shin, towards our knee, our hip, and even up to the back and beyond. So it really does have it can have a significant impact on our overall well-being. Now, also, when you're running, keep in mind that from a rigidity standpoint, that foot has to be able to withstand up to 3 to 4 times our body weight in load through it. So really important little or complex structure here. Now, in addition, the foot also has arches. It has 3 arches, one on the inside here, one on the back, on the outside, and then one, sorry if you guys, this could be a little bit difficult to show, but one on the underside of the toes. And thanks for that, Andrea. So what happens here is those arches, the arches is one of the strongest structures known to man. And so if there's tissue that runs from the underside of the foot, that tissue is there to help provide support to that arch. And you can see in that bottom left depiction there, what happens is when the big toe actually bends backwards, it tends to tighten up that whole system. And what happens is the arch actually lifts up. And when that arch lifts up, it provides us with that rigid lever and helps us to propel ourselves forward into that next step. So those structures on the underside of the foot really serve as springs, if you will. And so if we go over to the right side of the diagram, as those structures as they lengthen on the underside of that foot, they become tighter. And those as a spring would do, they tend to store energy. And when we propel ourselves, when that foot stabilizes, when it becomes more rigid, and when we come forward again, what happens is there's a release of that energy that's stored in those structures, in those soft tissues, and again, it helps to propel us forward. And Paul's going to talk about that a little bit coming up here as well. So we like to make ourselves sound pretty smart. We're going to talk about the gait cycle. We're not really that intelligent, but the gait cycle is just simply a walking pattern. And so what we should see with a walking pattern in an optimal alignment is we're going to land on our heel. We're going to fall to the outside of our foot. We're going to roll over to the inside of our foot, and then we're going to push off of our big toe. And as you can see in this depiction or in this video right here, this guy's running, so he doesn't have much of a heel strike, but you can see where that foot really has to be able to adapt and mold to the ground and anything that may be underneath that foot right there. Now as that toe bends backwards, that arch lifts up, and it's that arch that lifts that really, again, allows us to get into that propulsive phase of the gait cycle. And this is a great video just to depict that. So that's a very high level overview of the anatomy of the foot.
Fantastic. Thanks so much. So Paul, we hear lots about people having flat feet. Can you talk to us about the types of feet and foot alignment that you see coming into your office?
Sure. First of all, again, seems Craig, thank you for everybody showing up. It is very warm out here out east. It's been a hot, sweaty day. I'm stuck in a room right now. So if you see a few beads of sweat, that's not because I'm nervous, it's because I'm hot. But yeah, so essentially there are two sort of, as we would describe it, 2 foot types. There's the high arch supinated foot. which is essentially when that structure is really quite high. So in through the midfoot, we see a really significantly high arch, which Craig was talking about earlier. So that's a sort of a high arch supinated foot, meaning that it sits towards the outside. This is the outside of the ankle. And so that foot will tend to lean a little bit laterally. Structurally, there is also sort of a pronated or flat foot, which is typically happens when the gaps in between these midfoot joints are quite significant. This is a pretty flexible foot, and this is kind of a great example of how a foot can become slightly overpronated. It hits the ground, there's not a lot of stability and structure to it, and as a result, of course, being the inside, that foot tends to roll inward and flattening that arch out quite significantly when they stand. So a couple of things that you certainly think about when you're dealing with a sort of a supinated foot or the high arch foot, that foot tends to be a little bit stiffer, a little less shock absorbing. Whereas on the opposite end of the spectrum, when you have the sort of flat foot or sort of pronated or rolled over flat foot, that foot tends to be a little bit better at shock absorbing, but also can overstress some of the structures if it does tend to pronate a little bit too far. This video here is sort of a depiction of the foot in action. This is what the foot should look like as it impacts the floor. So certainly as Craig was describing through the gait pattern, the first thing that happens is that there's a little bit of a lateral heel strike. Then the foot falls into that midfoot stance where everything flattens down. And then as the foot recoils, like Craig was showing with those sort of the spring-loaded stuff, you can see that the heel bone will pull itself back under and getting ready for that propulsion through the typical gait pattern into the toe-off position. So those are sort of the two foot types. You've got your high arch, stiff rigid foot, and you have your low arch or flat foot, pes planus it's called. And so, yeah, those are sort of your two options.
So how would
Sorry, you go ahead.
Yeah,
Andrew.
just how do you know what type of foot arch you have? I mean, there's kind of these two different obvious ones, but is there something that we could do at home that would help us figure that out?
Yeah, there's a really, really great way that you can sort of test this out. One of the things that we do is, we can do it in the clinic, and we can use pedograph, which will basically have you walk across an ink pad so that it'll take an impression of your foot structure and where the load pressure is. But you can do it at home by finding a bucket of water, a swimming pool, or something along those lines. Just put a little bit of water on the bottom of your foot, and you can step on. Typically what we would recommend is like a lunch bag, like a paper bag, a brown manila paper bag, or you can step on some dry concrete. When you step and walk through your gait pattern, you will recognize that there are different heights to your arch. The one on the very far left is going to depict that you have a pretty high arch. You'll only have minimal contact at the ball of the foot and at the heel, and then a big gap in between. People with extremely high arches will have zero contact in the middle of that foot section. Then you've got your normal arch, which is the one in the middle, which sort of is an even weight distribution. When the heel strikes the ground, you step into mid stance. The weight of your foot collapses into that pronated position. You get some contact with the midfoot, and then you toe off normally as well. And so you get a nice depiction of an even weight distribution from rear foot to forefoot. And then on the right side, you've got your low arch example, which of course is that sort of flexible, flat-footed person. When they step on that dry concrete with a wet foot, you're going to see an awful lot of contact of the foot structure against the ground. In most cases, it's going to look like a block. There's not going to be a whole lot of daylight underneath that foot. It's going to be pretty wet and a big square block. So those are sort of your three arch types. That's how you can kind of quickly determine whether or not you're a high arch, normal arch, or a low arch position.
Fantastic. It seems like, I mean, like you said, there's going to be people who are out and about, floating around, trying to get cool around the pool, etc. So something simple to do, and that'll give us a lot of information about just kind of where we start regarding arches. So now that we have a little bit better understanding of some of the anatomy and the kind of the main arches of our feet, let's talk about maybe some common issues that we have. Maybe Craig, do you want to talk about some of the common issues that you see in feet?
Yeah, for sure, Andrea. So again, I'm going to talk about the pronated foot. So that's that flat foot that we were talking about. Now, again, as Paul has suggested, that flat foot is really good at absorbing shock, but it's not very good at providing that rigid state to help with the propulsive phase. And so as a result of that, we tend to see a lot of overuse injuries, muscle overuse injuries in particular in that pronated foot, that flat foot. And we see that because we still need to be able to lift that arch and propel ourselves forward. So because the integrity or the structure of that foot isn't allowed to become rigid, we end up having to use muscles to achieve that propulsive force. And one of the injuries that we see quite frequently is what we call an Achilles tendinopathy. The Achilles, your calf muscles, sorry, this is going to be in front of my face, the calf muscles come down the back of the leg, attach right here onto the button where that blue dot is depicted. And so what happens is that those calf muscles become really overdeveloped and they continuously pull at the spot of that blue dot right there. And it creates a pain right over that attachment site. Another area that we will often see pain is right along the inside of the shin right here. And so again, another muscle called your tibialis posterior. What it does is it kind of slings around. I was talking about the sling, so it slings around the backside of the heel here, of the tibia or the shin bone, and then it wraps underneath the arch of the foot. And so what ends up happening is that muscle ends up having to try to lift that arch. So every time you take a step, that arch flattens, that muscle gets stretched, but then it has to work hard to lift that arch to help with that propulsive phase. So again, we often will see those shin splints happening through the front of the shin. On occasion, what we'll see is because again that foot doesn't have that rigidity to it, it tends to flatten out. That inside arch tends to flatten out, and so sometimes what we'll see is pain right here along the top of the foot. And it's just from wear and tear. From we see arthritic changes, we can see just general wear and tear to the joint surfaces on the top of that foot. And then finally, a very common area that we'll see pain is on the bottom of the heel. And so when we have pain on there, one of the diagnoses of pain in that area is what we call plantar fasciitis. And essentially, the plantar fascia, you guys have probably heard of it, but plantar fascia is just it's a tissue that kind of like a piece of beef jerky, if you will. It's sinewy and tough, and it attaches to the base of the heel right here, and then spans out into the toes. And so what happens is, again, for that propulsive phase to take place, that plantar fascia gets stretched out, and so if you constantly fall, if that medial arch keeps falling inward, what happens is that plantar fascia just gets torqued on over and over and over again. And so oftentimes people will describe this pain happening right here at the bottom of the heel.
So Paul, you must see a lot of this. I know that's certainly a common reason that people do get orthotics, but tell us a little bit more about that plantar fasciitis as well as kind of the supinated foot issues.
Sure. So as Craig was saying, obviously plantar fasciitis, I'll tell you completely, it's the number one complaint that I see in clinical practice. People come in complaining of heel pain. Now, it's my job to differential diagnosis, to determine whether or not it's more of a strain on the plantar fascia, or is it more fat pad issues that are underneath the heel, or is it, maybe they just impacted the ground with too much force and caused a bit of a bone bruise in the area. There's all kinds of different conditions that present in that area that we kind of figure out and then go from there. But plantar fasciitis is probably the most common. The challenge with the what we describe as that supinated, or what I would sort of say is that pes cavus, that rigid foot type, is that foot, when it of course impacts the ground, unlike what Craig was talking about, that foot doesn't do a great job of absorbing that impact. So it hits the ground, and I tell all my patients on a day-to-day basis, it's like a block of wood hitting the floor. And when that block of wood hits the floor, of course, it doesn't absorb impact exceptionally well. And so therefore, all of the bony sort of areas of the foot that come in contact with the ground, for example, your heel, as well as your forefoot joints, they take on a lot of stress and strain. So your plantar fascia, as Craig was saying, that attaches here at the base of your heel, in a high arched rigid foot type, that tissue is always going to be really quite tight. And so then the foot hits the ground, it tries to expand, and then it adds that added little bit of increased tension. So then you get a lot of repetitive stress right there at the base of the heel. So inevitably, what we sort of recommend is trying in some way to figure out how do we alleviate that repetitive impact and that repetitive strain in that specific area. From there, we then move on to the metatarsal region, which is kind of up at the balls of the feet. These are your toes up here. So at the ball of the foot, right where that blue dot just showed up, those are your metatarsals, and those are essentially the heads of the metatarsals. If you think about it again with that high arch foot, that's going to be an area of significant amount of force and impact. So when that bone or foot hits the ground, what you can kind of see about these metatarsals is that specifically 2, 3, and 4, they're really skinny, tiny bones. They're not big, fat, and thick. If I can show it here, this is number 1. This is number 5. They tend to be a little thicker and more robust. They can manage some of that weight bearing a little bit better, but 2, 3, and 4 are really skinny. So once you start loading that extra bit of pressure into that area, of course, those guys will get irritated and uncomfortable as well. So we work on better weight distribution with that particular area. Next, we would sort of see that in a sort of that high arch and what we describe as supinated foot position would be your lateral ankle. So if the arch is on this side, the lateral ankle, as that foot stands up, because it tends to lean laterally towards the outside, what you see is a significant amount of pull and strain along the muscles along the side of the foot called your peroneals, and they all come in along that lateral side of the ankle, and you're constantly yanking and pulling on them because the foot tends to lean in that direction. So we'll see a lot of repetitive stress, irritation, and repetitive strain issues with those tendons and ligaments along the lateral side of the foot. And then finally, the one thing that we will see often in that sort of high arch supinated foot is stress fractures that can present themselves along the base of the 5th metatarsal. So this is the outside portion of the foot. This is the 5th metatarsal, which leads into your baby toe. And that metatarsal is, as I said earlier, similar to the first, is a little bit thicker, but when you're supinating or tipping towards the outside, you're putting a lot of load stress along that metatarsal. And doing that repetitively over and over and over again can lead to fractures in the middle portion of that metatarsal, which tends to be, again, the skinniest portion. It's fat up at the head, fat at the base, and then skinnier in the middle. So you may have a tendency to see the overloading leading to a stress fracture in that area.
Wow, lots of information about the foot and so many different things that can go wrong. But you can see by those models how many different bones and ligaments and muscles are going on there. And I mean, if you think about it, it's a small surface really that all our weight has to come down over and over, step after step. So no wonder there's so many different problems that we can have. So I think we want to talk about things most people don't know about their feet, maybe a few myths, if you will. Let's start with the common thought that flat foot can be reversed just by strengthening some of those small muscles. Craig, what can you tell us about that?
Well, first off, I'm going to say that the literature really doesn't support that. And anecdotally, I don't really see that either. What we see, in particular in that person with a flat arch, again, the problem there is oftentimes is that we're already overusing muscles to help provide some support for that foot, to help with that propulsion piece of our gait cycle. So if we're trying to strengthen muscles that are already being overloaded, overused, then the chances of a successful outcome are pretty poor. Secondly, the muscles that would be more responsible for changing the shape, and they don't really do a great job at changing the shape of the foot, but they're the smaller muscles in between the toes and these little joints. And unfortunately, like I said, they don't really do a fantastic job of changing the shape of the foot. They can pull some of those joints a little bit tighter together. But in all honesty, what I tend to do more than give people exercises to improve that arch is I refer these people on to people like Paul for orthotics.
So Paul, how would you handle this? Let's talk a little bit more about the orthotics, this common diagnosis of plantar fasciitis, as you mentioned. Tell us a little bit more about that.
So again, to Craig's point, more often than not, as much as I said, we can see plantar fasciitis in both the flexible foot or the flat foot, plus the high arched foot. It's when they present 99% of the time, it is going to be that flat-footed person. They're going to come in, the structure of the foot and the integrity of the foot collapses under the weight of their body as they walk. That puts a lot of tension to the bottom of the foot, and the plantar fascia at the base of the heel gets overstressed or overstrained. So in a case like that, a couple of things that we certainly want to do right off the bat. Number one, snug up and support that tissue really, really well. So whether it be an orthotic, a custom-made one, whether it be a really good brand of off-the-shelf insole, just providing that lift or that support underneath the foot to try to take that constant stretch away and really hold and stabilize that tissue, takes the tension off of the base of the heel, and then over a period of time, that tissue has the capability to just heal itself. If it doesn't and it lingers, then of course I'm going to refer to my colleagues like Craig as a physiotherapist. Chiropractic, sometimes there may be some joints that are stiff and not moving as well as they need to be. We may call in one of my colleagues as a chiropractor to get in and get some mobility back in a specific joint. Massage therapy, treating that tissue and just kind of really working some of the muscles of the legs. A lot of the times what we'll see is that plantar fasciitis case, there's a lot of tightness and strain through the calf muscle. They tend to be short and tight, and that puts tension in this direction on the heel bone, and then the stretch puts it in the opposite direction. So a lot of things there to really look at and support and stabilize.
Yeah, absolutely. So that sounds like there's so many different things that we can actually do. And thinking about that, talking about orthotics will weaken their feet. So you're supporting, I hear lots of support, but is there a fear that that's going to weaken your foot, or can you help explain really what happens when we're adding that additional support?
Sure. So what happens in that case, of course, is that people often come in going, well, if I wear an orthotic, am I not just going to allow everything to just get super weak? And essentially, then I'm going to run into other challenges or other concerns. How I sort of best describe it to my patients is that I'm not looking to immobilize the foot. People often think that if an orthotic goes in there, it's stopping my foot from moving. That's not at all what we're trying to do. What we're trying to achieve is better functional mechanics. So for example, if we talk about that flexible flat foot, as that foot collapses, it puts a lot of tension and strain on the soft tissue structures throughout the foot. So if I can successfully get an orthotic in there that stabilizes that tissue, takes the repetitive strain off, then what we're going to do is we're going to reduce the repetitive impact. The other thing that you got to keep in mind is that when we're dealing with orthotics, we're also designing them with the structure and the alignment. It's not all about just the stability or the positioning of the arch and things like that. There's also bony structural alignment, which at the end of the day, you can't do much about other than providing some support and stability. But again, coming back to my point is if we're not immobilizing the foot, we're not putting it in a cast, for example, we're not stopping it from moving. What we're trying to do is keep it moving within a normal range of motion so that we don't overstress and overstrain the foot structures and, of course, everything that's connected to it.
Okay, well, that makes a lot more sense. Thank you so much for clarifying. And, I think as we talk about things, we talked about, the different types of feet people have and the different types of arches. And, many people are wondering what position the foot is in. Like, let's say when you twist your ankle or something, does that have a difference on what type of injury you're more prone to? Craig, can you tell us a bit about that?
Yeah, for sure, Andrew. It's a great question. What happens is oftentimes we have people coming into the office and they say that they hurt their ankle or their foot on the weekend and they want an X-ray. And although we can send them for X-rays, it's often not warranted. And there's a couple things about the ankle. First off, again, coming back to the mechanics of that ankle, if we're looking at the front of the joint right here, when we put that foot I don't know if you can see that, into this position right here, if you twist your ankle in that position, the way that the bones are aligned, those bones are very, very structurally tight and sound. And so there's very little ability to rotate our ankles in that position. So if a person jumps off the back of a vehicle or falls off a ladder and lands into this position with a twist, unfortunately, what we may see, rather than a sprain of the ankle, is sometimes what we see is a fracture, a break. So we'll fracture some of the bones in and around that area. Conversely, if they twist their ankle with their toes pointed downwards like this, well, now this joint right here is really quite unstable and allows for a lot more movement. In this position, we really rely upon the ligaments, those elastic bands again, to provide that structural integrity for us. And so in that position, we tend to see a lot more sprains of the ligaments or strains of the muscles. Something else to note is X-rays are not 100% accurate in any part of the body, but in particular in the foot, they seem to misdiagnose rather frequently. Because there are so many bones, so many joints in here, oftentimes what we turn to rather than X-rays is a couple of tools that we provide in the clinic. We've got things like tuning forks or our own ultrasounds. And basically what they do is they emit high frequency sound waves. It'll push those sound waves into a potential fracture site. It rattles those bones, and what we see is people pull away from that tool. And so, for instance, even last week, I had a young lady who was very well known to me. She had hurt her ankle about 3 weeks ago, went to her doctor. She's a national level athlete. They immediately sent her for X-rays. The X-rays came back negative. So she came back walking around on her foot to me last week, 2 weeks into her injury. I immediately put her into an air cast, into a boot that protected that foot, got her to stop weight bearing on it, put my tuning fork, put my ultrasound over that spot, and it was lighting up like a Christmas tree. So we reached out to the doctor and said, look, I know the X-ray was negative, but how would you feel about maybe getting her in for a bone scan or a CT scan? These are the kind of the gold standards to detect fractures in and around that foot and ankle.
Wow. I think it's so good to know that there are things that we have in the clinic that can be really helpful in figuring out what's going on. Because sometimes, you got foot pain. It seems like maybe I need an X-ray or something, but it can be quite confusing with all those little bones in there. So I really appreciate understanding and hearing that story. Makes a lot of sense. So, we're talking about footwear as well. And Paul, this seems to be your area. What are the things to think about when it comes to different footwear with different types of those feet types and arches?
So again, a critical thing to consider is we talk about these feet and all that stuff day in, day out. We're all in footwear. Yes, maybe there's a few of us who live on a beach and never ever have to put shoes on their feet. But most of the people in the Western world are wearing shoes day in and day out. And so there's some critical things that you want to look at as a consumer when you're going out to purchase footwear. Number one is determine what your foot type is, right? You want to walk into a shoe store with an understanding of, do I have a high arch? Do I have a normal arch? Or do I have a flat foot? Because what's going to happen is the shape and the size of that foot is going to determine what type of shoe you're going to wear. So for example, if you have a really flat foot, that foot tends to spread out. It tends to, what I describe as pancake flat, which is ultimately going to result in your foot widening significantly, which is going to require you to have maybe a shoe that's a little bit wider than something that's a little narrower. On the flip side of that, somebody with a high arch foot that tends to lean towards the outside, those people are going to need maybe something that can be a little bit narrower through the midfoot, just simply because they need that added stability to try and prevent them from tipping further. Critical things to remember about footwear too is, what activity are you going to be doing? Are you walking a significant amount? Are you playing specific sports? You really want to pick the shoe that is relevant to the activity. You know, when you're working all day long, I can appreciate ladies out there, and no offense if I offend you in any way, but those tiny little pointy shoes, we all know that they're not super great for you. So trying to minimize the time spent in that footwear is obviously important. But finding there are brands out there that make slightly wider fitting toe boxes and things like that. But a couple of things about a shoe that we really want to make a point about. Number one, the first feature that you always want to look for when it comes to searching for a shoe is one that has, this is the back of the shoe, this is the front of the shoe. So the back of the shoe, this area here is called the heel counter. Okay, the heel counter itself should feel firm and rigid. So if I bang on that, it's nice and firm. There's a nice plastic piece here in the rear foot that's designed to help stabilize the foot at heel strike, which Craig talked about earlier. That's the first place that the foot strikes the ground. This is the outside portion of the heel, it lands. And so you want good stability there at heel strike. So the heel counter allows you to achieve that. The next thing that you want to do is you want to look to ensure that you have enough width through the midfoot. And that, again, knowing your foot type is important to find the right shoe that fits you here. Every shoe on the market is going to be a little bit different. Some are going to be narrower, some are going to be wider. That's important that you get a good fit through that area. You don't want to be too sloppy, but you also don't want to be too snug. Then we want to look at the toe box. Let's see if I can get that straight. The toe box is a real critical area. I would say a lot of the times that I see patients in clinic with toe issues, let's say whether it's a bunion forming, so your big toe shifting towards the second toe, or maybe you see a hammer toe where the toe's starting to kind of pop upward. A lot of the times that's irritated more by the shoe fit in the toe box. You need lots of space. So if you have a really wide foot, you want to go with a wider width shoe. There's a couple of different brands on the market, certainly, that have multiple widths. And so if they're there and you have that option, try it on in all the different widths to ensure that you get a good fit. Securing your footwear is important. I like laces. I've always liked laces, but you want to definitely have some sort of security there. Obviously, high-heeled shoes and things like that, not always the option, but certainly try to secure your feet inside of your shoes as much as you can. I'm going to talk a little bit about some of the concerns around diabetic feet. I think that's where we're at.
Yeah, just looking at some of those conditions and diseases that were commonly present with foot issues. And we did get questions before the webinar, lots of them about neuropathies.
Right. So neuropathies are a common symptom of people who have diabetes, long-term diabetes. What we see is some numbness, some tingling, or some altered sensation in the feet. The challenges that present is that, of course, you might not know if there is an issue going on in your feet when you have neuropathy, because you just can't detect it. Your body can't pick up on the concerns, whether you've got inflammation, whether you've got something, a hot spot on your foot. Your body just can't detect it. Your brain can't pick up that there's something going on there. And so therefore, footwear specifically in a diabetic case is crucial to get a really good fit. A couple of key things to pay attention to when it comes to fitting diabetic feet. Number one, reach inside your shoe all the time before you put it on. There's a couple of reasons for that. Again, I talked about if you have true neuropathy, you may not be able to feel your feet very well. And therefore, if you stuck your foot inside your shoe and didn't know that there was a golf ball in there, you would try to cram your foot in there going, it's weird, but I don't feel it. And that could really create some major concerns. A tack, a rock, something that's constantly repetitively digging at your foot could really lead to some problems. So reach inside. Second thing when you reach inside is you're looking to see if there are seams. And seams, obviously we know that shoes are all stitched together and there's all kinds of different layers of material. But if there is a seam in there that seems to be sticking out a little bit more, that will rub your foot on a repetitive basis, especially if you don't fit really well in that shoe. That will lead to obviously potential for skin breakdown and, of course, the worst case scenario, which is ulceration of the skin, which is very challenging as a diabetic to have heal because you're quite often the vascular stuff, so your blood flow is not as effective and efficient as it should be, and therefore that could lead to potential infections and things down the road. So always take the opportunity to look at your feet. I tell all of my diabetic patients, I want a mirror look every day at the bottom of your foot because most of the time you can't see it. You can't get into a position to really take a good look. So stick a mirror up, take a look at your foot and see what it looks like. If you see a hot spot, if you see any skin breakdown, you need to get it investigated with your physician as quickly as possible.
That's some great advice and really appreciate that. I think when we're thinking about the different conditions that we spoke about, and hopefully we've been able to provide the attendees with different ideas of what they're dealing with, what their foot looks like. But Cregg, what about when should you kind of take it to the next level? There's one thing to try to sort it out yourself, but when should you really reach out and seek some extra help?
Yeah, again, a great question, I think, Andrea. So first off, if you've hurt your foot, your ankle over the weekend or recently, that ankle, that foot has blown up, it's hot, it's red, it's inflamed, you can't take weight through it, I think that you should be seeking the advice of someone who knows what they're talking about. But further to that, and I think that's pretty straightforward, but further to that, if you've got knee pain, if you've got hip pain, if you've got back pain, that they kind of came on randomly, and you can't really pinpoint why that pain may be there, and it's kind of building over the course of time. Maybe it's been there for quite some time, like months and even longer. Then again, don't be surprised if you do see somebody, if they immediately go down to your feet. And there's very good reason for that. Again, the foot is the first point of contact with the ground. And so as such, if you're rolling over or if you've got that high arch, that also has an effect on the position of all those bones all the way up that chain. And so again, this is probably a good time to seek the advice of an expert. Obviously, if you're diabetic, again, I think that someone such as Paul again would be a great person to pay a visit to and just ensure that that everything is looking as best as possible.
Fantastic. So what I'm going to do, we're going to go into the Q&A, but you were just talking about seeking the help of somebody else. Certainly, if you feel like you need to connect with somebody, we have, as I said, clinics across the country. We would be very happy to help you out, whether it's from a physiotherapist perspective, whether it's a Pedorthist perspective, if you need to see an occupational therapist, or any of other health professionals that are within the Lifemark organization. Here's a way that you can reach out to us, connect to us in all of the usual ways. And we're going to talk a little bit about some of the questions that have come up. I think we already talked about that neuropathy, and I think that's great. Let's talk a little bit. I've seen some questions. We talked about that arch type, and can that arch type change over age? People talk about fallen arches or what happens, as you see people age. Is that a common thing that happens, or once you're stuck with the foot type that you have at, say, age 20, is that what's going to stick with you for the rest of your life? Who wants to tackle that one? Cregg, go ahead.
I think I'll take that one. Yeah, they can absolutely change over the course of time. The tissues on the inner side of that foot become lengthened as we gain weight and we go through menopause and so on and so forth. Or as we age, we often do gain weight. So again, that tends to have an effect on the arch of that foot. Someone like a diabetic, again, those tissues aren't as healthy as what they should be. So again, those arches can change over the course of time. So a good question.
Fantastic. So I guess that,
I'm just gonna, sorry, Andrea, I'm just gonna throw in the foot type that tends to change the most is, of course, that sort of low arch, flat-footed positioning. That'll start to lower more. Again, that person who has that sort of high arch or sort of tipped out supinated foot, we can see them tip further. Not super common. There's a couple of conditions that come along with that. But that high arched foot tends to be, again, slightly stiffer. Not as much change over time with that particular foot structure as you see with that low arch, flat-footed position.
Okay.
And even further, sorry, Andrea, further to that too, traumas, injuries to the foot. If you're tearing ligaments, if you're tearing muscles or have injuries of those natures, then of that nature, again, there is going to potentially be some changes to the arches of your feet. In fact, you'll see quite oftentimes a person will come in and one arch looks normal and the other arch has fallen, and you ask them about the history of that foot, and they report to you that they've had multiple sprains on that one side.
So it's almost cumulative over time too, if you keep kind of that repetitive spraining or straining. Absolutely. What about bunions? Can they be prevented? Can orthotics help with them? Lots of people have those bunions where they see that kind of big bump on the outside of their big toe. What can you tell us about that? People are asking.
So a bunion, or the technical medical term, is called hallux valgus. It's a shift of the IP joints, or the distal IP joints, and what you see is that big toe starts to shift towards the second toe. A lot of the time when we see that happen, or me clinically, it's usually due to excessive pronation, which is rolling towards that big toe. So you're now tipped over significantly further than normal, pushing a lot of load stress towards that big toe at the toe off phase of gait. But also what I tend to see is, if you look at the forefoot positioning, in a sort of an ideal forefoot position, all of the metatarsals tend to sit parallel to the ground. But in a case where I tend to see a lot of hallux valgus, or that bunion formation, we'll see the forefoot is quite slanted up into what we call a forefoot varus position. And so that forefoot varus being tilted like so, when they hit the ground, of course, they have to drop towards their big toe to level the foot off. And as a result, they put a lot more load stress over towards that great toe. And that causes a lot of forces generated onto that joint. And of course, then you get the shift, and that creates some challenges. Lots of people present to my clinic that have a big shift in the big toe and zero pain. That's because range of motion in that joint is still okay. It's when you start to lose range of motion in the joint, or it gets what I would describe as gummed up with some osteoarthritic changes, that's when pain will really start to set into that joint.
Okay, that's great. Thanks so much. Now, what about when people are talking about replacing their orthotics? They get the orthotics. Orthotics usually are not an inexpensive tool to have in your feet. How often should they be changed? Is it a once and done, or how do we look at that?
So there's two ways that I look at this when it comes to orthotics. One, it's look at the materials. So for example, this is an orthotic here, but this is a soft, flexible orthotic. It has some give to it. It has some flex to it. It's typically, in my case, designed for somebody with a higher arched, stiffer foot. We want to add in a cushioning, some shock absorbency. So I'm going to tend to use that with a stiffer foot. Then on the flip side of that, this one is a polypropylene plastic. More rigid, less flexibility to it, therefore trying to provide more stability to that flexible foot. So I look at materials. How long are they going to last? Well, of course, the more rigid material is going to last you a little bit longer. The softer material maybe needs to be replaced a little bit more often. But here's the rule of thumb. If you get an orthotic from any practitioner and you're still comfortable because it helped with whatever you were having concerns with, it's still working and it's still doing what it was intended to do. But if you want to kind of think benchmark, look at about 2 years. Somewhere between 2 and 3 years, you should at least make another visit to your practitioner to say, hey, are these still in good shape? Do they need to be refurbished? Do they need to be replaced? That's kind of what I would suggest.
Great. I think that's a good guide, 2 to 3 years. We are seeing, well, we're winding up here, but we're seeing a lot of questions about heel spurs. What are they? What should I do about them? Is there a treatment? Craig, can you tell us a little bit about these heel spurs that we hear about?
Yeah, so heel spurs are interesting because a lot of times we find them coming in on imaging, on x-rays in particular. The people come in and they say, yeah, here's my source of my pain. I've got a heel spur, or sometimes they don't have no pain, but yet they see these heel spurs on x-rays. For the most part, the heel spurs don't cause a great deal of the pain. The reason that those heel spurs may develop on occasion, what will happen is, again, with that plantar fascia, where in its attachment to the heel, that constant tugging of that plantar fascia along that line of pull will develop. The body basically develops a bony outcropping to help with that transmission of force. So typically it's not the heel spur that's causing the pain, but it's more the plantar fascia that will cause the pain. And so in that case, there's a variety of things that we can do. Paul talked about some of it already, the stretching and you can put a golf ball underneath that plantar fascia to try to get a release there. But very frequently, again, I'm coming back to an orthotic.
Fantastic. Well, I think, you know, Jonathan has had fingers on fire in the chat. Thank you so much for answering the questions. Again, we can't give any specific medical advice or individual advice, but I hope that you found some good value in here, learned a few things about feet, maybe learned a little bit more about what you thought you knew or a few myths that were debunked. If you do have individual questions or problems, we know feet can be sore. We're on them all the time. We may not be wearing the right shoes we're now hearing that is appropriate for our arches. We might have to be in these pointy toe shoes for whatever fashion reasons we feel are necessary. So make sure you do get help that you need, because we have one set of feet for our entire lives, and they have, as Cregg said, many, many, many miles that we want to put on them. And we hope that you've found some value in today and that we can help you walk a little bit further. As you heard earlier at the start of our session, the PC Health app has lots of challenges that you can join if you need a little extra motivation to get out there and get walking. I do want to say thank you so much to both Cregg and Paul for sharing your wealth of information. You will have difficulty seeing both of these fellows at the same time because they are in different parts of the country, but we have some great practitioners from coast to coast to coast. So please seek help if you need it. Otherwise, take some of this information and go get out and get your steps in. We thank you all for joining us on this evening, and enjoy the rest of your evening. And I will say, go Oilers. Thank you, everybody. Have a good night. Bye-bye.
Have a good night, guys.
Thanks, everybody.